That's a really good question. Um, there's no easy answer to why people like myself do what we do. And, here we are at a gene therapy meeting, and there are thousands of people like me who are committed to pushing the frontiers of knowledge, to finding new ways, essentially, to fight cancer to fight disease using genetic tools. For me personally, I think it comes through sort of a number of reasons why I do what I do. One of them is purely on the sort of the academic level. I recognize that we've really reached a point of diminishing returns with the conventional therapies we have to offer. Again, these are chemotherapy, radiation therapy, and surgery. And these treatments can be dialed up in their intensity, but they don't necessarily improve or greatly improve the outcome of a particular patient. In fact, we really have reached a point where the toxicity of the treatment can sometimes actually trump the anti-tumor effect. So the patient can suffer from the treatment more than the tumor suffers. So trying to find an answer to that is really motivating, because as a clinician, and a clinician taking care of children with cancer, and when I sit on the bed and take care of that child, or I'm looking across the room at the parents, and we say, okay, let's give drugs to try and get rid of, for instance, the most common pediatric diagnosis, cancer diagnosis, that's acute lymphoblastic leukemia, or ALL. So when I say, look, let's give some drugs today and get rid of this problem, I'm giving drugs that for the most part were developed decades ago. And in fact, drugs that were actually developed 50 years ago. And we have, as practitioners and as oncologists, I think done an excellent job understanding how to get those drugs into children and how to improve outcome. But in the last 5 to 10 years, this sense is that we have really maximized the potential of these types of therapies that were generated decades ago. There's no real point mixing and matching these chemicals that we have available in the bottle that was developed yesterday to get better effects for tomorrow. It's just not going to happen. So something new has to happen, some shift, some paradigm shift has to happen. And I think that falls to people like me and my colleagues to really provide that impetus, to provide that next step forward. I hesitate to say leap forward, but if I could just move the marble one revolution forward. And the way I think about it is, what can I do as a pediatric oncologist to deliver new therapies for children and big children, adults as well. And in nonprofit academic centers, that means, what can I make? What do I have available to me? What is essentially out there that I can work with in the laboratory and actually put into a child or put into an adult? And that is immune cells. So what motivates me is this sense that something different has to happen. Some change has to happen, because otherwise we are just going to go on as we are, giving these drugs, and we'll understand that a certain number of children will be cured, but importantly, we'll know that many of those children who are cured will be damaged. For instance, if you are a 30-year survivor of pediatric cancer, common age to get pediatric cancer, ALL, is about 5. So if you're a 35-year-old, that's a young person, we'll know that a significant percentage, 40+% of those people will be damaged, will be unhealthy, not working, not having families, and not being productive in society as a direct result of giving drugs that are 20, 30, 40, perhaps even 50 years old today. So something new has to happen. We have to improve survival, and we have to improve the quality of survivorship. So that's sort of the academic reason that motivates me.